Hello to our listeners. My name is Beth, and I'm really looking forward to this conversation today with Dr. Brittany Peters. She is a doctor of social work and also an LCSW, as well as being a master certified addiction professional. And today she's come on to talk with us about supervision, specifically the element of clinical leadership. I'm really looking forward to this conversation because her work has really focused on excelling in clinical leadership and clinical supervision. I think for many of us, the process of stepping into a supervisor role can be really intimidating and scary. So I'm grateful for Dr. Peters to come on and speak with us about how to demystify some of this process. Thank you so much for joining us.
Yeah, thank you for having me. It is a pleasure.
For our listeners, why don't you take a moment and tell folks about yourself and about your work and how you really started focusing so much on supporting early career clinicians and then also supporting clinical supervisors.
Yeah, thank you. Thank you. So I got my start in the field in 2007. I started working with intimate partner violence. And from there, I went on to do a little bit of work with eating disorders. But I really started to hone in once I had my clinical internship at an inpatient substance misuse disorder clinic, where we were working with individuals who were in a diversion program for prison. And so from there, I worked with the rural population in substance misuse, dependency drug court, early childhood court. And at that point, interfacing not just with the judicial system, but also supporting those who were trying to get their children back through, here in Florida, we call it Department of Children and Families. So they were very rewarding experiences. And during that process, from working with intimate partner violence and substance misuse, I had a total of 3 clinical supervisors towards licensure, and each one of them had a varying style in how they provided supervision to me. And so that was my first, exposure to, oh, wow, this is different depending on who I am getting supervision from. And so I went on there and got licensed, and through the course started to also look into my own pathway to becoming a clinical supervisor, and continuing to work in leadership roles as a supervisor for outpatient substance misuse treatment, and being a director, assistant director. And at each level, I realized the growth pathways for those who are seeking licensure are many, but that it centers around how important the supervisor and what they do for the supervisee that really makes the difference. And so when I developed my private practice, I wanted to make sure that I provided quality supervision. And I really started to look at, okay, are there theories to supervision? Are there, ways that I can enhance my clinical leadership, my style of supervision? And how can I do that to really ensure that those who seek supervision from me feel equipped to work within the field?
Amazing. Thank you for coming on. And I think you bring up such an important point is that stylistic difference. For me, I had 2 clinical supervisors at different sites during my, what was then called an internship in California. And I'll tell you, it made all the difference in the world that I had very good supervisors. And I got lucky because that's not always the case. But they had so much influence on the work that I was doing and my confidence and my place within organizations and like the way that they would advocate for me and things like that. I appreciate this backbone that you have around kind of the concept of leadership, because it really is part of the equation that I think is easy for us to overlook. You had mentioned these different theoretical models surrounding supervision. Can you spend a little time talking about those? Because I think even for folks who supervise, we may not know, we may not really know, like, why are we doing what we're doing?
Yeah. It's such a great question, right? And to fairness, I'll say I also teach. And one of the things I found is until I really taught the clinical supervision course, I too had no idea there was an entire textbook full of theories surrounding supervision, right? And what I'll say is reflecting on, as you said, the experience that we have with our own supervisor, I can see the difference in how, if one supervisor in particular, it felt like therapy. While I had another supervisor who really challenged my views on how I looked at my cases and what clients really needed in order to grow. And so when we think about prominent theoretical models, there are psychotherapy-based supervision models. And so what you'll see in that is a supervision model that is based in psychodynamics. With that, you find that the supervision is patient-centered. And so the supervisor really shows up as more authoritative and an authoritative guide. And with this approach, I think you'll find that new clinicians in the field tend to gravitate towards this, mainly because being new in the field, we may feel, I don't know what to do. And I want someone who's going to give me the answer, right? How can I get my client to absolutely do this? Or how can I get them to open up very quickly? And so I think that's one piece of that psychodynamic approach to supervision. We also see that it is supervisee centered, and there is a focus on the supervisee and their emotional processes. So allowing them to learn through the experience, which can increase their stress. But as the supervisor, you are helping them to process that, right? And so reflecting again, I said that first supervisor felt very much like a therapeutic session for me. And I can reflect and see where she very much had a lot of these approaches and strategies in providing clinical supervision to me. Now, there are a lot of relational themes that show up when we consider that psychodynamic. And so the supervisor and the supervisee are really working through various processes within their therapeutic relationship. That's just one model. Another model that I think is important, and when we think about psychotherapy-based models, again, I am just outlining the psychodynamic, but there's so many other. There is a feminist model. There is a cognitive behavioral supervision model. There's a person-centered supervision model, very much related to Carl Rogers' approach to therapy. And so you can see supervisees working together with that supervisor to very much mirror those approaches. One of the models that I think is important to my own style is this integrative model of supervision. And so what you'll see here is more of like a systems approach. And in this space, we tend to emphasize that supervisee relationship within the context, right? So we recognize that it exists within the context of various influences. And so not just what's going on with the client and the supervisee, but within the institution that the individual may be working in. And so really focuses on helping the supervisee to develop adaptability within those various challenges that they may experience in working with their client, but also some mutual empowerment between that supervisee and then trickling down to, of course, the client. And so with their integrative models, like I said, the systems model, I think, is one that resonates more with me, mainly because that last supervisor that I had, that's where I started to see the challenge, right? Hey, have you considered how the community influence or the system that the client is currently involved in? So I mentioned my experience in working with dependency drug courts, how that may be influencing how the client is showing up in session, and how important it would be for you to understand that system so that you can further support that client as they are working towards their therapeutic goals.
Amazing. Thank you. With therapeutic models, we think about the concept of goodness of fit. Can you speak a little bit about that in application to the supervisor supervisee relationship and how you see that play out?
Yeah, in goodness of fit, right? We say that we, in working with our clients, should consider what is best based on the client's strengths, right? Their available resources. And sometimes a model that is most comfortable for us is not what's best to treat that client. I think that when I consider your question, what really comes up for me is this gap between research and practice, especially when it comes to supervision models. In that, I mentioned earlier as we were talking, right, that I didn't really know there were so many models of supervision until I was tasked with teaching the course. And so I say that to say that I think that many supervisors may not be familiar with these models. And so I think where the goodness of fit, where we can really look at this, is number one, challenging ourselves as supervisors to dive into the literature on this and consider what is my approach, right? So understanding how am I showing up as a supervisor first, and then establishing a process of consulting with supervisees prior to taking them on, knowing what your approach is going to be, and understanding what they need. So here in Florida, we're regulated, and so we can have no more than 25 supervisees under our license. So, you can look at that a little bit like a caseload, and with that, you want to be intentional about who you are bringing under you, and really making sure that you are a good fit for the goals that that supervisee has and where they're trying to go in their career, but also for how you teach, how you consult, how you counsel in your supervision process. And as you grow and continue to learn, then you start to be able to navigate different approaches and integrate them as you learn them so that you can take on more interns while choosing the fit that is best for that particular intern. I think to start off with, it's important to recognize where you are and what's going to be a good fit in supervising for you.
Yeah. Well, you bring up an important point about choice, and also where my mind went when we don't have choice. So, like, looking at, for me, my master's program employed supervisors. We had our own counseling center. And so the supervisors, there were many there. And I think there was an opportunity to switch if it wasn't a good fit. But fast forward to my first internship site, and my job interview was with the clinical director, not with the person who was ultimately going to be my supervisor. So I didn't know who I was signing on for.
Mm-hmm.
And I got very lucky and had a great supervisor. But, in that case, it's like, especially in agency-based environments, it's like, well, we have one supervisor. This is who we work with. And if you're going to work here, then this is going to be your supervisor. And I think many of us can relate to that with clients as well, that we get funneled clients regardless of whether or not we are specialized with their particular needs or if there's even a good fit. And do we have flexibility within that system to try to change it, or do we just have to suck it up and deal with it? And there's some complexity there. Can you speak to that a little bit when we don't have the opportunity to meet in advance with somebody as a supervisor and they are just kind of plunked on our desk in a file and we go, okay, I'm doing supervision with you?
Yeah, Beth, your experience is the experience of many, right? In that we go to an organization and they have one qualified supervisor on site. And so unfortunately, that is the person. Or we find ourselves in a situation where we can't afford to pay for supervision outside of the organization. Or some organizations limit and say, hey, we don't want you talking about our clients outside of the organization with an outside supervisor. And so for the supervisee, that can be very limiting. And in hearing this, they may say, man, will that limit my growth as a clinician? So there are a couple of things, because you're right, it's very complex, right? And also speaks to a little bit of a power dynamic there, right? Is that I am at the mercy of my organization to receive supervision, and they have a goal in mind as well, right? They want me to keep seeing clients. That supervisor is also typically a leader within an organization, so they're vested in. They don't want to hear that I'm saying I'm really struggling with these notes. I don't think I can do this. And are they going to respond well? Can I open up to them? And so I think what's important for supervisees is to prepare themselves to ask those tough questions, even in an organization, about what they can expect from clinical supervision with the individual and differentiating that from administrative supervision. Administrative supervision being, this is what the organization needs us to do. This is your caseload. These are some of the outcomes that we're seeing. This is the time frame for notes, and this is how your compliance is to, okay, but clinical supervision, your ability to help me learn how to diagnose, to help me learn how to conceptualize cases, to help me work through feelings that I may have as I am being assigned cases. What can I expect from that? And also, here's what I need, that I may be showing up and questioning my own skill development. What resources do you have as a clinical supervisor outside of this to support my own growth? And I think by doing that, right, you're bringing to them, hey, I am learning that these are going to be different. I want to grow. And these are the areas I want to grow in. And so I'm hoping that this also prepares the supervisor to go, okay, this person knows that they are in a learning space when they show up to clinical supervision. And so they are going to present with, hey, this is a bias that I am experiencing, or this is some issues of countertransference that I'm experiencing. What can you provide me with as my clinical supervisor?
You bring up a really good point there in kind of differentiating the different types of supervision, but also sometimes how it gets muddy depending on the system. And I think the other part about supervision, and I'd love to hear your thoughts on it, I think for many clinicians, supervision, becoming a supervisor somehow can feel like the next step. It's like, okay, I'm a therapist. I feel competent as a therapist. And now what? And so we can step into this kind of leadership position, but really without a lot of awareness or knowledge of how to do it and how to navigate it. What it reminds me of is when I, in my career, was initially promoted from one position into another level and really had no right being there. And it wasn't in a clinical supervision capacity, but like, it's like, I wasn't trained in managing. And I didn't, I mean, like, oh, I want to be a manager. That's the next logical step, like keep climbing that ladder. That was drilled into me by the systems, if you will. But I really had no business doing it because I didn't have the time or the capacity to be more deliberate in that. And I look back on it and also realize, like, how often does that happen for supervisors? That they're like, okay, well, you're doing really well as a therapist here, and we have an opening for a supervisor, and we would like for you to apply, and like, it'll give you this much of a pay bump. And so here you are, and now you are a supervisor. And you're like, okay. Can you speak to that a little bit? Because I think it is different. To me, it's a difference between like managing, quote unquote, and leading. And like my appreciation that those are two different things.
Yeah, I love just kind of listening to your self reflection in this space, right? Because you're so right. We reflect back, and I think it's how people say today, like, I can't believe I'm the adult right now. Like, people are trusting me to adult, and so we think about it in terms of what is the next logical step for clinicians. And just because qualified supervisor, that role of being a supervisor and helping develop other clinicians is a step we can take, is it the right step for me, for my clinical path, for my experience. And you are right. There's this idea that we are oftentimes promoted within our behavior community mental health organizations. There's a spot open. Here you go. You've been doing such a really good job. You are hitting your metrics and inputting your notes on time. You're seeing the amount of clients. And so there's this, I think, there has to be a process of self-reflection and what are your clinical goals? And also the idea of what does it really take to develop other clinicians? And so there are a couple of things with that, right? There is this idea that we are always learning as clinical supervisors because we know that there are various nuances we'll experience with clients. We know that times change. None of us knew we'd be going through a pandemic, which meant that there were shifts and pivots that we had to make as supervisors. And so I can say, in reflection of my own experience, I was not taught how to do telehealth because it was not something that a clinical program I attended was focused on. In fact, we were still going, you're going to be in the office with a couch and people are going to come to you, right? And so we started to see technology happen. And yes, there's going to be virtual therapy, but the pandemic really shifted all of us, not only into providing therapy through a digital platform, but providing clinical supervision through that same platform, right? And so I wouldn't say that I, got out of school and decided I want to be a teacher. That was far from what I thought I wanted to do. But here I am. And what I think is important is that I started to realize that it was important to me to help other people skill build. And so it's a different type of teaching, which gets into that integrative model of supervision, because instead of showing up just as within psychodynamic models, right, this authoritative supervisor giving and prescribing, when the integrative, you can be the teacher, the consultant, the counselor. And so you are shifting and pivoting based on what the supervisee is bringing in the space. But I do believe that requires you to be prepared to also identify what's going to come up for you as you are working with. And usually when I have individuals who say, I also want to be a clinical supervisor, we really look at where do we want to start, right? We don't want to start with just taking on 25 supervisees, but let's start with one or two and really developing how you want to support the process. Here in Florida, it's a 2-year commitment to someone's clinical development. You are seeing them weekly for an hour a week. You're really developing a relationship with this individual. But again, it is where we are also modeling good boundaries with the individual. We're going through ethics with the individual. And so there's so many topics that if we're not careful and not intentional about how we plan to become a clinical supervisor and what we want to address, we might just feel like we're just showing up and we're just shooting a breeze with individuals, but not really developing them. So really sitting down and doing a reflective process, I think, is important prior to going in, because we have to develop ourselves and continue to develop as clinical supervisors.
Many states will say, okay, in order for you to provide supervision, you have to be licensed or have been licensed for a certain period of time, and then complete X number of continuing education courses, and then go, initially, and then every 2 years, something like that. When you say that you've taught clinical supervision courses, can you speak more about that? Of like, are we talking like a 6-hour, or is this like, no, I'm actually really developing clinical skills, which is not to say, I mean, like I would be the ultimate hypocrite to stand here as the founder of a continuing ed company and say, you learn nothing from continuing ed. But that these are two different concepts where it's like, I'm going to get the bare minimum that I need in order to be able to do this per the board's minimum requirements, versus here's the training and deliberateness that I need to really knock this one out of the ballpark.
Mm-hmm. Yeah. It's such a great Great question, right? Is that the course that I took to become a clinical supervisor was this 8-hour clinical supervisor course. Very different. It was a continuing education course, right? And what I found, and even just researching courses that I could take, is that not all courses were created equal, in that some courses would provide you forms so you could figure out, do I need to do a contract with them? How do I keep track of it? Developing a learning plan, right? Versus none of that stuff is required by our state in Florida. We're not required to do a contract with the supervisee to offer them a learning plan of what topics they can expect. There are some requirements in terms of date, time, how many hours they're actually seeing clients, but not really getting into that, delving into a deep dive of these are the things that we need to cover over the course of our relationship. The supervision courses that I've taught, interesting enough, are electives within graduate courses. And so we have to think about that, right? Is that an elective, first of all, means that the course is one that they are developing, and this may go into like the required curriculum. It may not, depending on, student enrollment and different aspects of like the outcomes over a couple years. But also that students have to choose and be interested in that. The other part of that is they're getting it so early in their career that if you're taking this as a graduate level course, it's clearly before you are licensed, right? And so you are reflecting on, what did I learn? So now we have this 2-year licensure process, and maybe I graduated from graduate school years ago. So pulling back up that information while you're trying to be a clinical supervisor is definitely hard, which I think is one of the critiques I could say for how we look at continuing education courses around preparing to become a qualified supervisor, is how can we link research and practice, and also how can we link skill development for qualified supervisors to preparing them to go into this process. I will say I've taught graduate courses at the MSW level, so Masters of Social Work level, but also for those who are working towards their doctorate. And I've seen it show up there too. Now, when we have doctoral students going through their program, you will find that if they are taking an elective, oftentimes they may already be licensed and going back and saying, hey, I want to go into a doctoral program. But many times it is that master's level elective where I've taught it, there's a textbook, and we're going through it. And so I definitely think that not all of us get the benefit of going through that course in preparation for, hey, you might become a qualified supervisor one day, and here's what we want you to know.
It makes a lot of sense. And I'm thinking about my own program and the specialization tracks that it had. You weren't required to take one. But, if you wanted to work in intimate partner violence, or if you knew you wanted to work in addiction or whatever it was, even there implies a deliberateness of, I can look down the foreseeable future in my career and hope that it's going to go this particular way, which is, for supervision, again, like kind of this, it's very different from the like, oh, I guess this is the next logical step. And so I'll do this thing and I'll take the hours of continuing ed and I'll call myself a supervisor and we'll get that additional paycheck or whatever it is. Those are two very different ways of looking at it. And I think it probably follows suit for specialization within therapy models as well. That we can be a jack of all trades and be a little bit good at a lot of things, or we could be really good at a couple of things because we really invested in them and committed to them.
Yeah. And to your point of specialization, right? We think about post licensure or even just post masters is when we start to go, do I want to get training in, cognitive behavioral therapy or trauma focused CBT, or do I want to get training in EMDR? And so we start to kind of hone in, versus our programs tend to be very generalist. And so, like you said, being able to think down the line is important, but also hard when you're in that particular point in stage of your life. And as a supervisor, we are absolutely gatekeepers, right? We are helping to retain those in the field who may be questioning, am I good at this? But also helping to shift those who go, you know what? It's honest. I don't love this. There's too much coming up for me. I still want to support. And what are those other roles that I can support those who are in need, right? So those who may say, I really wanted to do this work, but I find it difficult for myself. And so the supervisor and supervisee relationship is so important for so many different reasons.
Yeah, absolutely. And I think for early career professionals, we're so often we don't get a ton of choice of what our site might be. Like there's competition. There are only so many sites available who are taking associates or interns. And so if you get the phone call and someone says, we'd like to offer you a job, you say, okay. And we know that there is such a high burnout rate. Clinical supervisors are tasked with a lot of stress. It's more than just, okay, how can we best support this client? It's like, how do I navigate the administrative minefields? What do I do about the fact that they keep telling me that I need to work more overtime and I can't anymore and I'm burned out and they keep giving more clients? Like there's so much that can come up in those early sites that probably is ending up in the lap of a supervisor. And like, how is a supervisor approaching it?
Mm-hmm. And you bring up, they are tasked with so much. There's risk associated with being a clinical supervisor, right? Because you are saying, I don't work for XYZ organization, but I am taking you on, and this is if it's outside supervision. And I am hoping that you are making decisions based on my guidance, based on my consultation to you, and notifying me when there are adverse clinical outcomes, right? And hoping that that supervisee is willing to, number one, have that type of relationship where they respond well to your guidance so that they're not out there engaging in malpractice or having boundary issues with clients, because that can be scary too, right? That someone is working under your license, but maybe not quite taking the feedback when you notice that there are some concerns with how they practice, right? And so that is very much a concern. And then as a supervisor, hearing that, they are getting assigned more than what I think is clinically appropriate, the number of clients that they should be seeing, especially at their skill level, right? And so we see that there may be that overlay of appointments. I remember an intern, sharing with me that, they're going to schedule 12 sessions a day for me, staggering them to account for no-shows. And so we really talked about, burnout within that role, especially being at community mental health. Yes, I can see where the leadership may have proposed that, but is that going to work for many clients or many clinicians? And wanting to help that in turn advocate for themselves in those situations, because we see it happen. I was looking at a study that looked at supervision dilemmas and how supervisors and supervisees navigated these programs. And one of the things was they found that supervisors were not always providing the critical feedback needed to truly develop the supervisee. Also, supervisees being defensive showed up in that study as well. And this was, they had 94 total participants, 29 supervisors and 65 supervisees. But those were the themes that came up, right? Is that when navigating these dilemmas that are often found within the supervisee and supervisor relationship, there are times where the supervisor may not be equipped to provide the critical feedback needed to the supervisee. And when they are, the supervisee may not be in a position where they can receive that feedback and then use that to, again, skill build, which should be happening within that relationship. And so we think, well, what do you do with that, right? Because I definitely have experienced supervisees like that. is really looking at how do we structure supervision. So going back to this is what I'm going to expect. These are some of the things that we're going to talk through, and topics that we'll cover. And that was one of the recommendations from that particular study that just said, hey, there are ways for us to improve and enhance addressing the dilemmas that show up within the context of clinical supervision.
It is such an intimate process. And really, I guess, almost in the best of circumstances, it's a really intimate process because your whole self is showing up in therapy with your clients. And hopefully your whole self is showing up in supervision. And that's a lot of grist for the mill for a supervisor. Can you speak a bit about what you had talked briefly about earlier, kind of this idea of the systems coming into play, how they're impacting the client, how they are impacting the clinician, and helping to develop that in supervisees?
Yeah, your questions around how systems impact the client, therefore impacting the clinician, and then impacting the supervisor. So what I'll say to that is, first, there's so many layers, right? Is that we have to prepare our supervisees to be able to assess for what systems their clients exist within, and this considers like the ecological systems theory, right? Is that we have our individual, we have the neighborhood and community where they exist, and then we go from there to not just their community, but the state, our nation, and really looking at how there can be an impact that trickles down to the individual. And so when working with our supervisees, we want them to not just complete the assessment in a way that says, hey, I'm really trying to identify these symptoms so that I can then diagnose and then identify the intervention that could best address and reduce these symptoms, but also considering, well, what are the other things that are going on with this client? What are the resources that they're lacking? What are their internal resources, their external resources? What strengths do they possess? Because you mentioned earlier this goodness of fit, but when we do that, if we don't assess the systems within that our clients are existing in, then we may not choose the intervention that best fits. We may be going, I really love this particular intervention. I want to do this with the client. And then we find that the clinical outcomes are not what we expect them to be because it wasn't a good fit. And so one of the things that we might consider that shows up for clients is clients who show up within legal systems, right? That shows up a lot and is really hard for supervisees and I would say for some clinicians as well that are done with their clinical supervision, right? Is how do we navigate building therapeutic trust while also knowing that this client was referred to you for an assessment because they are judicially involved, and or I'm working with a client who is actively going through a divorce, and what that might mean for when I'm subpoenaed, and those complexities and HIPAA, and all the things that make clinicians, especially new clinicians who are still undergoing supervision, go, how do I navigate this? What do I do? Who is the authority figure here? Because do I have to say all of these things or tell all of these things? Also, when we don't think about legal, we may think about issues of discrimination or inequality, and considering how we help the supervisee to conceptualize cases, considering that can also, discrimination and inequality can also exacerbate mental health symptoms that our clients are experiencing. And how do we support a client, validating their experience, and also ensuring that we engage in anti-oppressive approaches with those who experience discrimination and inequality. So I think that those are a couple of systems that we may oftentimes find ourselves serving clients within.
You bring up some really good points of kind of this trickle up theory, really, like what's affecting the client is therefore affecting the therapist, is therefore affecting the supervisor. And then in the trickle down side of it is like whatever the underdeveloped areas are within the supervision are just going to then play out across these other hierarchies. And, I'm thinking about confrontation, for example. This is like a really common thing that we talk about in supervision, um, and also has very different implications when you consider cultural factors and bring that into the situation. How do you work with supervisors to develop more awareness so that they're bringing that into their supervision, and they're thereby making that an inherent part of the work that the clinicians are doing with their own clients?
Um, so when working with supervisors, one of the things that I think is most important is first assessing their comfortability with confrontation, because like you said, it's one of those things where we have some who shy away from it. Right. And we have those who may be too strong in that area. And so it's developing this balance. Right. So I think that the first thing is ensuring and really asking ourselves, did we get a great introduction to the use of confrontation within the clinical space to begin with? And from there we go, all right, if yes, then I can proceed here. If no, then I want to explore and do some reflective work around my discomfort with confrontation, right? Like, what does it mean to me when there is confrontation? Because you may have to utilize that skill within the supervisee supervisor relationship, right? And so being able to reflect and identify what is coming up for the supervisor. So recognizing that although we are in a space where we are helping develop, we too are going to have issues of countertransference with the supervisee. We too are going to have areas where we're uncomfortable with something they're doing. However, we recognize that we don't want to disrupt the relationship in a way that doesn't have them come back, because we want them to know that this is a learning lab. This is where they should bring these issues. And so some of the things that I like to talk about are not just that reflective process for the supervisor, but being able to identify what are the areas that you tend to shy away from, and how can you address things in a way that you are giving constructive feedback, but also considering what are you missing in that particular exchange with the supervisee? Because sometimes it may be that we are, as supervisors, missing a key element that the supervisee needs to further develop. And so, yes, we want to use confrontation while also going, but what's the piece that's causing them to engage in something I'm having to confront them about?
Very good points. Can you discuss more some examples about how supervision dynamics are impacted by sociocultural differences and similarities in supervision? So, how is it playing out when we have different genders, when we have, or same, how is it playing out when we come from different cultural backgrounds, and the awareness that we're bringing into the room as supervisors?
One of the things I think is very relevant for supervisors is being able to develop and distinguish between cultural humility and cultural competence when working, right, with our supervisees. And so cultural competence really focuses on, well, I'm acquiring this skill and learning these facts. But cultural humility really looks at, all right, this is the ongoing process, right? It is not some place that I'm arriving. I'm critiquing myself. I am reflective. I'm open to learning from the clients, which then means that I'm also, because the supervisee is the client at this point, I'm open to learning from the supervisee. And this is without imposing our values and bias on the supervisee, but really listening to where they're coming from. And so we start there, right, with this idea that sometimes there's going to be this sameness. And then other times there's going to be complexities and differences, in making sure that we are inclusive, but also recognizing that there is intersectionality that also exists within these relationships. And really what we see is that the therapeutic relationship is to some degree cross-cultural in and of itself. And so there's power dynamics that show up. There's this idea of making sure that we recognize and acknowledge that there is a power differential and imbalance that shows up within that relationship. And if we say that, hey, we are teaching our supervisees to recognize the client's right to self-determination. Well, as supervisors, our supervisees also have a right to self-determination. Now, within limits, right? That doesn't mean that we want to coach them or consult them in a way that they don't engage in ethical practice, but helping them to become the clinician they want to be. And really, we should be aiming to equalize a little bit of that power. I think that in modeling it in our supervisee and supervisor relationship, it really helps the supervisee to then do it within the work that they do with their clients. Especially because we want to, again, make sure that we recognize that when we engage in cultural humility, it aligns with a social justice agenda, and really helps to identify that our clients are experts on their lived experience. And so, again, we do this with our supervisees to, in turn, help them to do it with their clients.
The phrase that was coming to mind when I was listening to you, and it's pulling from the relationship between therapist and therapy client, what I've heard said is you can only take a client as far as you've gone yourself. And this idea that if we are hoping to support social justice and culturally humble experiences, are we doing that work as supervisors, and are we being deliberate with that as well, so that we create that spirit in our supervision, and then that's hopefully the spirit that gets passed on down the line? Because one thing that kind of blows my mind about supervision, and I think always has and always will, how many clients are you indirectly touching?
Oh, yeah.
And that, just that awareness is like kind of a trip. And it's like, so what tone am I setting in my sessions, and how does that carry forward and ripple down through levels of mental health care?
I almost wonder sometimes if, going back to your thought about, like, is it the logical next step for me? If potential supervisors consider that, right? So I mentioned earlier, a practical example is Florida. And now this is a new regulation, so I'll say that it didn't happen. It probably happened over the last 5 years, that they said your caseload as a clinical supervisor is no more than 25 supervisees. And to your point, that means, well, for each one of their caseloads, you are indirectly, that's your caseload. And so for me, I tend to not take on more than 10. I hover around about 8, and that's still a lot. But because I also think about 25 is a lot. And prior to that, there were qualified supervisors that had well more than 25. And so you're right, there's this indirect work that we have to recognize we're doing. And you have to be willing to spend that intimate time getting to know. And then there's that trust within the supervising and supervisor relationship, that clinician to come to you about new intakes that they're assessing, bringing that raw data so you can trust their decision making, and also help knowing that they're going to say, here's what I'm presented with. And then you're listening for them to present to you, this is how I'm conceptualizing what's going on. This is the intervention. This is the diagnoses. So I literally, with my supervisees, have them go through the DSM, and I say, okay, justify your diagnosis. Literally, criteria A, you say, that they have depressed mood. What is that evidenced by? What in your assessment did you say matches that particular diagnostic criteria? And doing it in that way, I tell them, hey, you're not going to be asked to do that when you are at an agency. They just want you to pick it. But the benefit of getting down to that is it really helps us to learn how to apply what we're being taught, not just in school, but then what we're being asked to and what we're learning. Because remember, when we get out of school, it is practice-based learning at that point. And so what are you learning in real application of what you're doing?
I think you're absolutely right. And the other thing that's occurred to me, how many years have I been licensed? And I'm still referring back to conversations and lessons from my supervisors, and still sometimes asking myself, like, what would so-and-so do in this situation this many years later? Like, it really does touch you and shape you. And that's a lot to kind of consider and work through. But I'm also hearing your proposal, which is let's do this deliberately. Let's do it thoughtfully and not have it be the next logical progression in our careers. It's like, how do we do this right? And really learn, why am I doing what I'm doing? What am I trying to support in this supervisee that's going to then trickle down into better mental health care for the society at large? No pressure.
As you're speaking, I go, wait, I mentioned earlier that this is this 2-year process, but really, if it's done right, you are reflecting on the lessons learned from your clinical supervisor, and that relationship continues beyond the required, because typically you are reaching out to that individual, right? You're going, even after I'm fully licensed, you're going, hey, can I grab your ear for a second? And not just related to client cases, but related to my organization is telling me this. And I'm wondering, could this be right? Or should I be asking more questions because the license is mine, right? We're teaching them that, hey, this is your license. You don't want malpractice on your license. And then, maybe they are contacting you about a career choice. And that's another part of that, right? Is preparing them to go, how do I learn when this organization or private practice is not a good fit for me? How do I find what that is? And so it's not just reflecting on the lessons from your clinical supervisor, but really a lifelong relationship of there's trust there. And again, mutual empowerment that, I'm going to reach out to you. And for me, I always think back that my prior supervisees who are now licensed, because I've worked with them and I know their strengths, sometimes I'm reaching out to them and saying, hey, I know you have a lot of experience working at the hospital. I have a question about the system because I encountered something. So you then start to build this network of other clinicians that you can consult on cases with, which is an important part of clinical practice.
Yeah, absolutely. So when listening to this conversation and going, oh, okay, like I want to do this. I want to really lean into the process of supervision and build out my skills and be more deliberate. Where do they start? Where do clinicians start?
First, looking at, of course, your state and seeing what is required. Typically, it is a CEU course of some sort. I would look at courses that offer practical examples of how to work with supervisees, but also courses that provide information on how to structure and organize that. And what I mean by that is very similar to when we are working with clients. We know there's a process of intake, treatment planning, closure, and documentation of what it is you're doing with that client. And although many states may not require explicitly all of those things, setting yourself up as a supervisor to be able to understand how do you intake supervisees. So very much just taking what we do with clients and going, what course is going to prepare me for that? But also considering your risk right? We want to really be risk adverse, to your earlier point of you are inadvertently seeing every client your supervisee is seeing. And so, what are going to be your standard protocols? What are you asking them to do, right? Are there situations that you want to set up and say, hey, at intake, I want to go over these things. I also want to develop a learning plan of topics I definitely want to go over in structure, and then guiding them up into the process of exam taking and getting licensed. And an example I can give of that is even in my structured process I mentioned earlier, I always start with a consultation call. I think that's very important to make sure goodness of fit. What are your career goals? Make sure I have the experience. And if I don't, I know some great supervisors, and I'm going to refer you to someone who has that background. The other thing that I like to do up front is I like to go over ethics. Let's talk about laws and rules. Let's talk about ethics that govern our practice. And let's give real life examples. So our board meeting minutes are public here in Florida. And so those provide examples of where malpractice has come before the board. What I like to do with interns is just to look at number one, first of all, let's see who's on the board so we know what the board is. But then also we can see what happens in these cases. We don't want it to be a scary process, but we want them to know that we are being called to do good clinical work. And the first thing we want to do is make sure we center ourselves in what is ethical practice. And going from there, and then we start to go, all right, what are the cases that we're working with, and how can we, start to learn to diagnose? Can we become familiar with? Can we lean into? I always remind them that, hey, the DSM is not just in the back of my head. I have one in every office I have to show up in, because sometimes I need to pull it up, and, it makes all the difference to remember, oh, wait, I need to look at the last 12 months, not the last 3 months, or they need this much in order to grab this. And so where we start as supervisors is really looking at, first, what are my state requirements to become one? What am I going to need from a CEU course? If I am in graduate school, is there an elective that I can take? And really looking at, is this going to set me up to structure my practice around this? Because again, what we're doing is really clinical skill development for future clinicians.
In our therapeutic work, we often think about like case consultation, and you have spoken to it a little bit, kind of the importance of that network. What have you found to be really effective for supervisors to find and then maintain and nurture that network of other supervisors to be able to have those opportunities to consult and to grow?
Yeah, there are a couple of things. I find that most of the time we are not prepared to realize that supervision actually continues after we become licensed, after the requirement. But when we reflect, we often do it. We say, hey, I have this case and I need, some support. So I remember when I was, after I finished EMDR training and after I did the required supervision, I was like, I still need some support here, right? So I was so happy that my suite mate also had gone through the process and could allow me to, bounce a couple ideas off and things that I was experiencing with some of my clients as it was new to me. And so what I find is oftentimes there are groups that we can join that conduct supervision for supervisors and for clinicians. Those can be really, really meaningful if that is something that you're into. The other piece is really connecting with those who you've worked with in the past, and who may, because, we want people that think like us, but really we should be choosing clinicians that don't think like us, right? That can see it from a different lens. So calling up that clinician that maybe tends to look at something a little different and going, let me run this by you, because that's where we see really the stretching of our skill, right? Someone who's going to say, hey, I'm going to stretch you just a little bit into, your outside your comfort zone. But if you are open to it, And that's the own network that we built, right? It's the network we built through group supervision, through our colleagues, and through really being open to the fact that we are constantly learning.
I love the point that you just made, and I think you're absolutely right. We really want to find somebody who thinks just like us. And I've certainly found it very helpful when I've consulted with colleagues that don't, because, like, what am I missing? Especially if I go speak with somebody who has exactly the same perspective or I know has a similar approach as I do, I might be missing something. And so I'm glad you brought up that point, that the workability, if you will, around, like, I need to continue to grow and this is how I continue to grow. And it's okay to have a growth edge and be deliberate and open about what I might be missing. Um, I think, Dr. Brittany, you have challenged our listeners with so many really important ideas. And I am grateful to you for spending this time with us and sharing some of your expertise. For listeners who want to learn more about you and your work, what's the best way to do that?
You can always check out my website. It is www.leadclinically.com. I'm always happy to do consultation. Also, you can follow some of my work on Instagram, and the handle is at Lead Clinically as well.
Fantastic. Thank you again. For our listeners, this was Dr. Brittany Peters. Thank you for joining us. This has really been enlightening and also a call to action.
Thank you for having me.